Down to 3 lectures. Hope you have a good weekend. Studying for pediatrics. Personal test wasn't too bad. Test wasn't too bad. We'll get into sepsis. You can clown this video all you want, but it is spot on.
Sepsis makes me feel this way. Take a minute, unit. Blue meets her striker. She's tagging 2. Meets her striker. Check 102. Meets her striker. Let's ship for do. Meets her striker. To work a bit. So head get weak. Check the UA. For bacteria. Chest X-ray. For pneumonia. Cultures too. For bacteria. Get your sepsis on. Go ahead, get your sepsis on. Go ahead, get your sepsis on. Get your sepsis on. Go ahead, go ahead. Get your sepsis on. Get your sepsis on. Go ahead, go ahead. Get your sepsis on. Get your sepsis on. I'm bringing sepsis back. Those microbes aren't prepared for my attack. Check these broad spectrums I've got on the rack. I narrow therapy by culture track. Give them all the bosun. Septic bay. 4-liter bolus and you're still the same. I start depressors through the central vein. I hope your BB starts to make some gain. Get them all the fusion. Meets her striker. She's tagging 2. Meets her striker. Check 102. Meets her striker. Let's ship for do. Meets her striker. To work a bit. So head get weak. Check the UA. For bacteria. Chest X-ray. For pneumonia. Cultures too. For bacteria.
Sorry, that's like 5 minutes of the music video. So you can go back and Google that yourself. YouTube. I can nerd out. So, precursor to getting into sepsis right here. Very important thing. Again, very cavalier in the emergency department. If we even think of going towards sepsis, we have criteria. That's what we talk about. SEERS. Not to be confused with QSOF. I'll explain that. These are good decision-making tools. We suspect sepsis. Reference material objectives. Pretty much the same standard here. And then let's just get your brains working again. Shift from pediatrics to this. What is the priority of managing this patient? Right off the bat. Culture's not so much. We need to start some fluids and antibiotics. Okay. Fluids and antibiotics. That patient's blood pressure is not looking so high. When you bring that up, you probably start antibiotics concurrently. Still got a little bit of time. You just shotgun it, order cultures. So wherever you think the source of that infection should give you an idea of what you need to reach for as far as antibiotics. In a pinch, you can always just do vancomycin in a pinch. That will hit most of the nasty bugs. Okay? Widespread inflammation. When we get into SEERS, we're talking about systemic, so widespread, and then organ harm when that starts getting worse. It's usually going to start hitting the kidneys first, and start hitting the heart, lungs, and that affects mainly once we start getting sepsis, those veins get blown open and they can't perfuse properly. A problem with oxygen delivery, which is why we order the lactate to give us an idea of how bad is this sepsis getting, and it's causing cellular damage across the board, every organ system in the body with significant inflammation. Eventually, if that progresses worse, which is when people start to go severely downhill, multi-system organ failure occurs. Give us a good idea of all that. So, still remains high despite all the progress we've made in medicine. So, about 20%, one in five die. They come in a little too late, maybe they're already immunosuppressed, immunocompromised. So, once they reach septic shock, and I'll explain what that is in a minute here, we're looking at half of those people mortality. Sepsis is either suspected or confirmed. We don't always know where it is, but we need to take a good idea and look for that. Being UTIs are very common, urosepsis, pneumonia is very common, and then a lot of these dermatological things, which is why we have to check it. When we start having cardiovascular failure, what does that mean? Typically, that's going to manifest itself with tachycardia and hypotension. Gives us an idea of what cardiovascular system is starting to fail. We're getting into septic shock. Again, the hypotension and tachycardia should be an idea like, oh boy, this is not going well. So, increase in lactate gives us an idea that we're not perfusing well enough. Persistent hypotension, and then if we have to reach for vasopressors, that's a done deal, even though you fluid challenge them. What they say in the video, 4 liters, and it didn't change, that person's in septic shock. 4 liters should change your blood pressure in time. Here's your criteria. I would definitely know this. So your SEERS response syndrome, criteria right there. So fever, now they can be hyperthermic or hypothermic. Pulse rate, usually above 90. Get me above 20, and then a leukocytosis. Now, it can also be a leukopenia. So leukocytosis above 12, that's kind of your cutoff. Anything above 12, leukocytosis. Anything below 4,000. Anything below 4,000. And then we have all these other different general parameters that can look at those types of things. It just breaks those down specifically from SEERS criteria with what to look for. But you have your inflammatory parameters. A couple other things that are in there a little bit different. Some places do like to order a CRP, so C-reactive protein. And then the other thing that's a little funky on there is procalcitonin. If procalcitonin is elevated, it gives you an idea that it's either a lung or GI infection. So that's like an ICU type of thing. Internal medicine doctors love it if you order that on a patient. That's usually, they don't get that ordered until they're in the ICU. So you're crazy smart if you order that thing in an appropriate patient that you're concerned for sepsis or septic shock. Procalcitonin is a different lab that you can order. Comes back pretty quick. And then as we start pushing on, this is after the emergency department. Typically, they're in the ICU. They're going to monitor all these other parameters. Most of these organ dysfunction parameters, we're looking specifically at the GU, mostly the kidneys. And then we look at what other types of function the liver has, like a thrombocytopenia. If we have decreased platelets, the liver is being affected. So we have all these different types of things that we can order. We're looking at cap refills and physical exam, and then acute lung injuries, bilirubins, platelet counts, coags. Just gives us an idea of how bad our end organ damage is getting to. So here's another parameter. So Q-SOFA tool, this is more of an inpatient tool. I've had internal medicine docs go, what's their Q-SOFA? I'm not worried about that from the emergency department. That it was developed in conjunction with the sepsis 3 criteria. This is better for the inpatient if you have altered mental status or their tachypnic or systolic blood pressure below 100. Gives us an idea for outcomes if they have two or more. So recent studies, poor sensitivity to Sears is superior. Sears is superior. So having Sears does not confirm that infection. So just be aware, somebody comes in, they were just running outside in 110-degree temperature, and they roll their ankle, potential fracture, so they can meet all those potential criteria. They can be tachycardic, they could have an elevated temperature, but just because they are Sears positive doesn't mean that it's an infection. So just keep in mind that other things can match that and have an idea of where did that infection start. And here's this whole paradigm here where all these run together. So you want to cast a wide net because maybe it's a parasite infection, maybe it's just a virus, and maybe it's related to trauma or burns. Pancreatitis always likes to show its ugly head and show up a positive Sears when it's just a pancreatitis, not necessarily an infection. So this is just to show you I need to cast a wide net, but Sears criteria concerning for infection is probably going to be our biggest thing there we're going to be concerned with. So serum lactate, that's our best prognostic data. So has to do with anaerobic metabolism if the tissue is not perfusing, hypoperfusion. So increase in lactate means increase in mortality. Now, what other things can cause a lactate to be elevated besides hypoperfusion? What's all related to hypoperfusion? But what other types of things do you think you see a lactate elevated in? What type of events? We talked about seizures. Okay, somebody's seizing for a long time, you're going to have really elevated lactate. Should clear quickly once that seizure abates.
DKA.
Any other ideas?
DKA.
DKA, yeah, absolutely. And then you bring in somebody that's a significant alcoholic that went on a bender for like a week or a weekend. I've seen lactates as high as 13, 14. So that's because they have so much alcohol in their system that they're hyperperfusion. So just be aware of that. So lactate elevation, hypotension are independent predictors. So that one's elevated, that one's decreased, not good at all, not good at all. So if they don't clear that lactate, we help them clear that lactate by giving them lots of fluids. Giving them lots of fluids helps out with that. So higher mortality. So again, not very specific. I talked about those other conditions, but it should be a good gauge. You get a lactate right away with an I-stat typically. An I-stat with a lactate. So you get that right off the bat. Gives you a good gauge of where do I need to go. I need to make sure if I'm doing the right thing, that lactate should be decreasing. Should be decreasing if we're doing the right thing. If we're not going the right direction, get somebody else on board to help out with that. So what happens here, the immune response fails to control and overreacts to these invasive pathogens. So whatever that is, sometimes parasites, sometimes fungus, mostly bacteria. So early stages of sepsis, it's hyperinflammatory response right away, and then it blunts. It blunts after that. What happens there? What's the key term when I talk about cell death, programmed cell death? Anybody know what that cool word is? Apoptosis. Outstanding.
Oh, yes.
Apoptosis, nice. Sounds like it should be a name for like a Korean pop band. All right. So we have procoagulant and anticoagulant functioning. So in the extreme situations, we start dealing with disseminated intravascular coagulation. That is across the board, the entire body. We're dealing with micro and microvascular clot formation, and then it causes impaired tissue perfusion and then thrombosis of these small vessels. There's a cascade effect between those three, worsening the condition, if we're not moving in the right direction. So, things that we do, sometimes this can be subtle, be occult in nature, especially in our immunocompromised folks. They can start to appreciate very quick. Well, we want to use the Sears criteria, vital sign abnormalities, to give you a very good indication. That's almost the very first thing that I look at in a patient when they're being brought in by EMS, whatever. Look to see are they tachycardic, they hypotense, febrile, And then I'm going to do something to respond to each of those. If they're tachycardic and hypotense, they clearly probably need fluids. If they're dehydrated or they're getting into the realm of shock. And if they have fever, I need to be doing something about that. Giving them some type of antipyretic, usually Tylenol. And again, everybody's familiar, that's distributive shock. When we're talking about what kind of shock sepsis is. Essentially, it is a warm shock. These people aren't cold. Not a cold shock, they're very warm to the touch, they're febrile, they're vasodilated, histamine response, and they're trying to perfuse better. And compensatory, when that hypotension stops or starts, we're going to have that tachycardia start to compensate. Where do we see this at? We need to make sure we're checking all our organ systems. So, and especially if we're pulmonary, because if they have an underlying pneumonia, it's going to cause this to spread even quicker. So we have ARDS, acute lung injury. So we're getting more lung edema, so we're not perfusing very well, we're not pushing air, we're not oxygenating, we're not ventilating very well. So that's usually due to inflammation. So hypoxemia, so what we're going to see there, we definitely need to get these people on O2. And if they need to be ventilated or put on a ventilator with a definitive airway, keep in mind that mechanical ventilation doesn't always help out when the lungs are non-compliant. And then we start seeing chest x-ray, which show significant infiltrates. So this is why we consider intubating early with any altered mental status. Another spot we're going to see that. Common sepsis targets the kidney. Has a lot to do with also we're dealing with a UTI that maybe it progresses to a pyelonephritis, which is a upper urinary tract infection. So acute kidney injury. So we're going to see that either decrease in urine or no urine production. I'm going to have an idea, did they already have some pre-existing kidney dysfunction? And now where do we see that? Where we're going to see kidney dysfunction at typically? What lab? I know we haven't gotten into GU so much, but creatinine. Okay. Creatinine is going to give us an idea. If we have a baseline, they're already elevated a little bit. Now they're higher, it's not good. So if there's significant hypotension, that maybe that kidney's not perfusing properly. Coupled with these people are typically dehydrated at baseline. And then we always get worried about if I'm going to give them antibiotics, maybe these antibiotics are going to be nephrotoxic. Also be aware that if we have to give them an IV contrast, there's potential that we're going to be hurting the kidneys worse. How do I combat that usually? I give these people a liter of fluids before I send them, regardless of what I'm getting a study for a CT. If I'm giving IV contrast, I'm going to give them a liter of fluids before and a liter of fluids afterwards, just in case it's nephrotoxic to the kidneys. So again, remember, AKI is typically going to be related to renal ischemia. So kidneys are not perfusing as well as they should. We see the liver. So most frequent hepatic abnormality seen with this, we want to make sure we're checking these people's sclera, looking at their skin, looking for any cholestatic jaundice. So getting those baseline, this is why we throw the kitchen sink. We're going to get a C&P so we get all those liver function. We want to make sure that we're looking at all their liver function tests. Transaminases, alphos. So if those are elevated, it means the kidneys or the liver is taking a hit. We need to be concerned with that. So transaminase, bilirubin. Now you have to order a bilirubin separate unless you're going to order liver function test by itself. You can't order a BMP with liver function test. That is essentially a CMP, but if you order that liver function test separate, they will throw a direct bilirubin in there. So just be aware of that. Again, hyperperfusion, ischemia, but there can also be secondary from that immune response with endotoxins, cytokines, and immune complex damage. So essentially what's going to happen here, if the liver's taking a hit, it's probably going to slow the gallbladder down as well. Slow the gallbladder down, which opens the door for infection. Here's your GI. Most common manifestation is an ileus. So it's not perfusing well enough, it's just going to slow down and not pretty much come to a screaming halt. So this can occur for days after, which is why they want to make sure that these people can use the bathroom before they go home. So Not usually from an upper GI bleed. Not usually from an upper GI bleed. We'll get into that in block 3. Very rare in septic patients. But again, there can be small amount of blood loss, and pretty normal. You can probably get a positive WIAC, but that has to do with painless erosions within the stomach or due to stress, gastritis secondary to the sepsis. Clinical presentation, obviously, if the liver's being hit, we're going to have an issue with all these different types of products that are in the blood. So, decrease in neutrophils, decrease in platelets, which can also be a consequence of the DIC. If we see platelets dropping, this is getting bad. That means liver's taking a hit. And then fulminant DIC, if it gets to fulminant DIC, means it's completely spread throughout the body and is in several different organs. Very poor prognosis, very poor prognosis. So again, we talked about that lactate. Gives us an idea that we have a metabolic process that's occurring. Metabolic. And then, for some reason, these people have hyperglycemia. So, inflammatory response causes a release of cortisol, adrenaline, and then very rare, but we can see hypoglycemia. Either way, we want to check a glucose on these folks. Make sure that we need to either replenish their glucose or add insulin for hyperglycemia. So this has a lot to do with the hepatic system taking a hit. So depletion of glycogen and gluconeogenesis. A lot of times we'll see this in metabolic process that has to do with an infection as being one of the eyes that starts DKA. Makes sense? And then skin, we want to make sure that we're checking all these people. If we cannot find anything, we should be giving these people Trum Naked, especially if they're in a nursing home and they're bedridden. Chances are you'll probably find an ulcer. You might find some cellulitis. Maybe in a diabetic ulcer that's non-infected. So there's your cellulitis, your syphilis, fasciitis. Make sure we check these people for any petechiae that should not blanch. We have necrosis of the peripheral tissues from DIC. So, and then we get these lesions from intravascular infections that cause vasculitis, and then toxic shock syndrome. So, look for any necrotizing surgical source. What would be indicative of a necrotizing fasciitis? I'll talk about this as pain out of proportion. Somebody looks, they have a cellulitis, you touch it just very lightly. Pain out of proportion on exam should tip you off that is a necrotizing fasciitis. That you call surgery right away. No amount of antibiotics is going to take care of that on its own. They have to take that and debride it in the emergency department. So beware of those types of things. All right, I'm hitting this again. Do not delay the antibiotics. So when in doubt, if we're worried about an encephalitis, meningitis, a sepsis, those are types of things, it's okay. Let's get the antibiotics going right away. It could be doing the cultures at the same time. Again, it's probably an order set that says sepsis, and you just go through, hit that sepsis, and start clicking everything. IV fluids, antibiotics, all your labs. You're gonna get pan cultures, so definitely gonna get usually 2 different sources, cultures, a urine culture, and then if you suspect a source. So that person has a port because they have what? So kidney failure, typically for port, or they're under cancer treatment. So there's your Sears criteria again. Suspect that right off the bat. Say suspect, but obviously if they're lighting all those up, we'd be concerned. You're not going to get that white count right away, but you can have all 3 just looking at your vitals. Septic shock present after our initial fluid bolus. So everybody kind of puts a different gauge. I say that's at least 2 liters, and the systolic still sitting below 90. Very concerning, very concerning. And then a lactate greater than 4. Lactate greater than 4. So what's your normal lactate? 2 or less. So we've doubled it, we're concerned. When we start looking at our differential diagnosis, the biggest thing is that it's going to tell you which organ's going to get probably hit first, And then also gives an idea of what antibiotics do I need to go with. What antibiotics do I need to go with? I have a slide coming up here, it just gives you an idea of what we need to reach for first. So we look at all our different types of shock. Yes, somebody can have a distributive shock, but also have something else that's going on there. So maybe they're having a pulmonary embolism, cardiac tamponade, any number of the weird endocrine disorders. Those are always on my low, my differential, but they are on my differential. So remember, in different shock, 40% of these people are going to have sepsis. That's 2 out of 5. Unfortunately, children show up very late. They depreciate towards the end. They do very well, and then all of a sudden bad. So they lose their ability to increase their heart rate, which results in tissue hypoperfusion. So just be aware they look good until they don't. They look good until they don't. So tests are useful. Here's your test we talked about. So pan cultures can be blood cultures. 2 different sites is what they want. 2 different sites. So if they have some other thing that you're concerning about, maybe they had a central line placed, you may want to get a culture from that area as well. Blood cultures and urine culture. There's your CBC, your electrolytes. It's going to be your BNP, includes your renal function panel. Sorry, Titnally does not break it down to exactly what you're going to see in the military system and what you're going to order. I want to make sure we get that lactate, liver function panel, UA and everybody, because it's not everybody's going to present with dysuria or some type of discharge. A lot of these older folks will come in, they're just altered, and it 0 sepsis the whole time. You'd be surprised. Very important, low threshold when I get that ISTAT, that I'm going to get a BVG put on there. Gives me an idea if they are going acidotic yet, and then what should I address first? Do I need to address their metabolic issues, their ventilatory issues with oxygen adequacy? So type in screen at least, because it means we're thinking about giving a transfusion, but not necessarily. And then again, if we're suspecting DIC, we're starting to see that the liver is failing, and we're starting to see petechiae, and maybe they're starting to bleed from weird spots in their gums, we can consider getting all these coag studies. So for the most part, coag studies will give you a PT, an APPT, and then fibrinogen is a separate lab, and D-dimer is a separate lab. Anybody know what else you'd order a fibrinogen in? We'll get into it, I think this lecture, so very important in snake bites. Very important in snake bites. Okay, make sure we're looking big here. So everybody's gonna get a chest x-ray. Everybody's gonna get a chest x-ray. Give us a good baseline, do they have a pneumonia? Or give us a good baseline if they're gonna progress to ARDS. CT scans, again, low threshold for CT scans of these folks as well. We're worried about, did they perf somewhere in their abdomen? Did they perf somewhere? No, you have an idea without your physical exam, you push on their abdomen and it hurts. Like, oh, is there something going on in there that I need to look for? Perforated. So ultrasound, right upper quadrant ultrasound, typically for looking, we're concerned about a cholecystitis or choledocholithiasis. So necrotizing fasciitis, CT ultrasounds. And then are worried about an encephalitis meningitis, so we need to get a CT and LP. So again, we do not delay the antibiotics for these folks. Antibiotics are the game changer. When you're like, man, the emergency department's always giving antibiotics. Well, that's because that physician or PA has been burned by somebody that came in sepsis and they waited a little too long. The sooner we get those antibiotics on board, the sooner we can kill microbes. Okay, 2 separate sites typically. Gram stain and culture, you just put in the culture, it'll take care of that. And then we talked about other tests to consider is that CRP, procalcitonin. Check with your phase 2 site to see their inpatient teams may just want everybody to get a CRP and a procalcitonin. If that's what they want, go ahead and get it. Go ahead and get it. Okay, here are your cornerstones. So recognizing that, we look at our vital signs, we look at our ABCs, are they altered? What's going on? Early infection control, that is by antibiotics, via antibiotics. And of course, everybody now is getting a COVID test. because you can't put, you have two people with sepsis, one's coded positive 2 and the other one's not, you can't put them in the room together. So, and then we need to reverse the hemodynamic compromise. So make sure we do those ABCs because we can't get to antibiotics and fluids and whatnot unless we secured those. Infection control potential as well for surgery. If they've got a cholecystitis, that gallbladder needs to come out as infection control by removing that. So, make sure we're moving in the right direction. Think about what you're doing, what's working, what's not. That lactate is a great reference for that. Lactate is a great reference. So we need to improve preload. That's typically going to be from fluids and pressors, tissue perfusion, and then oxygen delivery as well. So 2 to 5 crystalloids, 2 to 5 liters crystalloids within the first 6 hours. Do not delay vasopressors. Now vasopressors used to just be given if you had a central line placed. Not too many people that are going to get to place central lines. They need to be ultrasound savvy to be able to do that. So, but we reach for those vasopressors very early. It's very common to give norepinephrine through a peripheral line down. Very common that we don't need to put a central line. But what we can potentially do is push dose epi. Anybody have any idea how to do push dose epi? So that being basic, he explains it. Take a 10 cc syringe, take out 1 cc out of that, and you're going to add 1 cc of crash cart epi. And you're going to push usually 2 to 3 cc's to get a response. That's temporizing, but you do temporizing until you get the norepinephrine at the bedside. Because norepinephrine is not like in a drawer in the room. You're going to have to come out of a Pyxis. It's going to take them a few minutes to get that. But you're going to push dose epi right there from the crash cart, and you're pushing that patient. It's a temporizing thing, meaning temporary. Temporizing. Okay, first assessing our ABCs right at the bat. They recommend 30 milligrams per kilogram of fluids. 30 milligrams per kilogram. So 1 to 2 liters. Now, normal saline or LR based on your hospital. So if you put 2 liters in and they're still in shock, do you think 2 more is going to fix it? No. Probably not. We probably need to think about pressors. Right, that initial bolus, and we're not there. Let's go ahead and we don't have to go full bore at the pressor. We can start it very low, maybe 10. So adequate perfusion pressure. Here's our agents of choice. Norepinephrine, number 1, because it works on both the alpha and beta adrenergic effects, causing vasoconstriction in the periphery and then inotropy cardiac. That means it makes the heart beat more efficiently and harder to help perfuse. And then vasopressin is going to be your number 2. Vasopressin is number 2. And then we talked about epinephrine, safe and equivalent, but that's a temporizing thing. We want to go with the norepi and stay on that longer. We're going to use that lactate to guide us, to guide our therapy with that. So that, in theory, theoretically, if the lactate's going down, it means we're restoring adequate tissue perfusion. So 1 to 2 hours apart, we're going to continue to get those lactates as long as they're in the emergency department, make sure we're moving in the right direction. So greater than 10% increase in that shows improved clinical outcomes. And then we want you to give broad spectrum antibiotics very early with what we think is the cause of that sepsis. So the Surviving Sepsis campaign says within 1 hour of recognizing sepsis, or in 3 hours of triage. Those are just time frames as far as references. I say as soon as you recognize sepsis, let's get it going. Let's order our cultures. Let's order our rainbow of labs and get going. So it's nice to have all those cultures. They'll need that, but those cultures aren't going to come back for 2 days. They're not going to make real clinical decisions until they figure out the bug. And that's going to be great. They're going to figure out the bug, but you still need to get all the testing done where they're going to do different antibiotics. Anybody remember back what the MIC was? The mean inhibitory concentration. So that's going to tell you which bug it is, and then which antibiotic is it susceptible or resistant, and then it's going to have a number next to that. The lower the number, that means the higher the chance that that antibiotic is going to kill that bacteria quicker. Remember back we always worry about COVID testing and then droplet control for C. diff as well. Here's how Chip Nally kind of breaks this all down for you. This is basically, you need to have an idea of what's going on, otherwise just bank and Zos. But you have these types of ideas on this. I don't think I have any questions where I'm asking you to pick a specific bacteria. It's more important that you know that we need to get antibiotics and fluids on board quickly. This is just a quick breakdown, I think 3 slides to give people an idea of what antibiotic. Other things that I look for to help me guide this, if I'm really confused, I can call infection control or call infectious disease and say, hey, I have this patient. The other thing is I'll look at, oh, this person's been in for sepsis like 3 times before. Oh, urosepsis each time. I'm going to go back and look at their urine cultures, and I'm going to say, oh, it was susceptible to this last time, and I'm going to start them on that if I think that that's what's going on. And then I'm going to double check their allergies and make sure I'm not going to give them something that's going to make this worse. Those are other things to help guide you with that. Use 5 of these, so no, I'm not going to test you on known antibiotics. Just know that there's a lot of crossover here. You're going to see a lot of vancomycin. You're going to see a lot of Zosyn. The other thing you need to consider here is looking at that person's kidney function. Some of these folks may need to be renally dosed, meaning we have to lower the amount of antibiotic because their kidneys can't handle it. That's where you pick up the phone and you call your pharmacist and say, I need this patient renally dosed. Maybe they had underlying kidney dysfunction. Maybe they have kidney dysfunction now because they're septic. All right. Check on learning. Questions on sepsis. Whopping 41 slides, so too much stuff, pretty condensed in there. Pretty simple. What else can you use in a pinch? Yeah. Good. C. You are correct. So, like I said, we need to correct the hypotension with fluids, decrease the tachycardia, increase the blood pressure, and then control the infection with antibiotics. Good deal. I'm going to get into anaphylaxis here. If I get you crying, I don't know what will.
Oh, my girl.
Thomas J. My girl?
want to harm?
Yes.
Rita, something happened to Thomas J. last night. He stepped on me behind.
I told him not to tease those bees. Can he get stung? Maybe I should go over and yell at him. Why not?
He was allergic to bees.
He's okay, isn't he?
There are just too many of them.
I'm from the Road by Anderson, and we've helped thousands of customers who were on a budget.
So before we get into that, by the way, he's like 43 years old now.
Yep.
Not a young kid anymore. I got busted like 2004 with marijuana and Xanax and clonazepam. Pretty sweet. Dated Mila Kunis for 8 years and couldn't close the deal. That's crazy. And then recently changed its name. It's they said he wanted a new middle name, so it's Macaulay Culkin Pulkin. Anyway, pretty downhill after that. Downhill. So let's segue into allergy and anaphylaxis. So a lot of you will get some experience with allergies, that type of thing. Typically, they put allergy clinics with ENT clinics. So you might get a little bit of time with both of those, but we'll talk about anaphylaxis. So what do people die from anaphylaxis? A lot of people think it's airway. Well, you have to get stung in the throat, or you're eating a peanut butter and jelly sandwich, you're not supposed to, and it's in your throat, sure. But the majority of people die from shock. So that histamine response blows the vessels wide open to go into shock, cardiac arrest, die. So that's why epinephrine is so important. Okay, reference material, 24 slides, and I know we're getting pretty close to time, so a few more minutes here. So we'll talk about all these different types of anaphylaxis. They're important. Most of the time somebody comes in anaphylaxis, you're looking at the nurse and they're going to know exactly what to be grabbing. So epinephrine, right off the bat. And then we have our H1 or H2 blockers. So epinephrine, intramuscular, single dose. Everybody knows that EpiPens have multiple doses in them. If you've ever taken a wilderness EMT course, there's a way to open that. You can YouTube it, and there's usually 2 or 3 more doses in there that you can get access to. Anaphylaxis, anywhere from every 5 to 10 minutes. I would say probably every 5. Every 5 you need to be dosing somebody. And then we get concerned about something called a biphasic reaction. So there are certain people, very small percentage, less than 1% of the time, that can have anaphylaxis and 12 hours later just go into full anaphylaxis again. That's why we make sure those people have all the medications. So no high risk, meaning they've not had a history of anaphylaxis, or if somebody comes in and says, yeah, I've had anaphylaxis, I've needed to be intubated before. I was like, oh boy, you're not going anywhere. Those are people that need to be observed for 6 hours. Wrong case. So this is where emergency medicine gets interesting, like what do I do next? Well, we're talking about just what general treatments. So we need to probably give them some fluids, and then probably another dose of epi. Another dose of epi, and let's go ahead and probably start those H1, H2 blockers. Potential for steroids as well. This is my favorite slide. Okay, everybody familiar? Okay, good. Serious allergic reaction. So, how does this happen? So we use these terms now, anaphylactic and anaphylactoid. Those were the terms that were used. But now we just say anaphylaxis. Anaphylaxis, as it refers to that whole hypersensitivity. And you need to have an idea, everybody responds a little bit differently. What are they allergic to? I would tell you everybody's probably allergic to bees or hymenoptera. We'll talk in the next section on what that is. Everybody has at least some degree, but they get a little well. Now, anaphylaxis is a whole different ballgame versus, I'm allergic to peanut butter, or I'm allergic to peanuts, nut allergy. I had a Ranger student on his way to Florida on a bus and thought he could eat around the nuts on the protein bar. He got an EpiPen on the bus. Outstanding. So just be aware that it can happen. We talk about foods, definitely medications. We don't want to cause those types of things. And then, yes, they can have allergic reactions to allergen immunotherapy. So those cause anaphylaxis. And then be aware of your latex hypersensitivity. Find that out during the IV lab because the colored Coban down there has latex in it. If you don't know, if you have that, make sure you pick up some of that, identify. Obviously, you have idiopathic anaphylaxis. Sometimes we don't always figure out what the offending agent was. We try to, but we can't. This is just a wonderful chart. I'm not going to test you on the pathophysiology, but just understand that it deals with antigens, B lymphocytes, and then histamine response. That is the body's way of responding to that. But unfortunately, histamine side effect is to vasodilate blood vessels, which is why we get concerned about shock. So classic presentation, so pruritus, so itching of the skin, flushing, and urticaria. What's another word for urticaria? Hives. So they're not wheels all over the body. We're concerned because once we start affecting different organ systems, now we're getting into the world of anaphylaxis. So a lot of people will complain of fullness of the throat even though they're doing just fine. They start getting nervous, chest gets tight, they get lightheaded. If they start feeling a lump in the throat, that's concerning that they're having laryngeal edema. So again, when we have multi-system effects, abdominal pain, cramping, nausea, vomiting, diarrhea, start having runny nose, conjunctivitis, hypotension. So that cascade progresses. So eventually decreased level of consciousness and circulatory collapse, resulting in the heart stopping. So you see loss of consciousness, cardiorespiratory arrest. Not good. Most of these within 30 seconds or 60 minutes of the exposure. 60 minutes of exposure. So faster those symptoms are coming on, the faster it's going to get more severe. So that's happening much quicker. We need to be very concerned. Clinical diagnosis. There's nothing that you're going to order in the emergency department that's going to give that away. Sure, you can probably get an IgE level later just to have an idea of how bad they have allergies, but nothing's going to give you this diagnosis of what is anaphylaxis. So, clear history of exposure. You always want to find out what were you exposed to. Can they recall? Were they bit by something? So, and then again, key is multi-system effects. Sometimes they can be delayed. We get that biphasic reaction. Be concerned about that, and that other mimickers can be there. So make sure. Most cases they come in. This is not an HPI patient. You need to be acting, getting all those medications on board, and we'll talk specifically what those are and those doses. Anaphylaxis differential diagnosis. Just be aware there's a bunch of different things, a lot of things that can affect the airway or vocal cords. Just be aware there's other things, means castaway net. I'm not going to test you on what else could this be. More importantly, you know how to handle it. You address your ABCs, look at your vitals. Anytime that something seems off, you should be doing some intervention to correct it. So always important to get that IV access early, get them on oxygen, cardiac rhythm, so safety nets in place, and then our first line therapies. Interesting one in there is decontamination. They were exposed to something, we don't need you getting exposed to it as well. So decontamination, when we're talking about insects, potentially we need to make sure that the stinger's been removed. That would be decontamination for them. Not to mention, most people, if they get marked by some type of hymenoptera, a lot of times they're going to release their pheromones on them, try to get them out of that area once they get stung, because they're getting marked and they will continue to sting that person. Continue. Severe anaphylaxis, securing the airway is the first priority. You have a patient that's severe anaphylaxis, because if you lose that airway completely, it obstructs completely, no luck getting that back. So potentially have to go to a cricothyroidotomy, but right there's the symptoms of that. Angioedema, look in the mouth, uvular edema. You can hear stridor, not stridor, stridor. That's actual like wheezing, the airway's closing out. So we need complete instruction to progression of angioedema. We're not getting that airway back. We are not getting that airway back. So you gotta think right. So anaphylaxis decontamination. So we need to terminate any exposure to whatever that might be. I talked about making sure that the stinger is removed. Mostly that's only gonna be with honeybees. Not typically with wasps. They can sting repeatedly. So epinephrine. Why? Epinephrine has both alpha-1, beta-1, and beta-2 receptor stimulation and activation. So it's going to decrease mucosal edema, hypotension, increase the heart rate, so some inotrope effects, and then also helps with bronchodilation and limiting further mediator release. So epi, you want to make sure you're giving them the max dose. Again, you may need more than one EpiPen. So IM stat is going to cause that vasoconstriction to prevent the shock. Help out if there's any laryngeal edema. Repeat every 5 to 10 minutes. We give that injection into the thigh and we count to 10. So they used to give it sub-Q, but it's much better, higher peak responses when it's given intramuscular. I'm not necessarily showing that to a patient, but surprise them. A cousin of mine married a special forces guy. He said, "Oh yeah, we need EpiPens." Got a couple of my guys that have a history of anaphylaxis, blah blah blah. Okay, and I found out they were just playing a game with each other. You fall asleep at a computer at work, you get an EpiPen. Stop that business. Anyway, most patients only need a single dose. But just beware if the patient is under beta blocker medication, that response can be a little bit blunted. And then if they are on beta blockers, maybe they took too much, just be aware the reversal agent for that is glucagon. Make sure you give that with an antiemetic. Most people give glucagon to are going to puke. And then there's potential for epinephrine infusion. I had somebody ask me, hey, if I don't have norepinephrine or whatever, you can use epi infusion right there, 1 microgram per minute, titrating to effect, or we can either push dose epi temporizing. So again, IV crystalloids. That's a distributive shock as well with anaphylaxis, similar to sepsis. So 1 to 2 liters isotonic, 20 mLs per kilogram in children, administered concurrently with epinephrine. So if that's not ready, doesn't mean that, oh, I'm gonna wait till that's ready. Whatever is ready to go, let's get it going. The fluids are ready first, that's okay, but ideally concurrently. Here's our second line, corticosteroids. So what do we usually give? Salmeterol, right? So 150, you have your antihistamines, your H1 and your H2 blockers. So diphenhydramine, aka Benadryl, usually give a whopping dose of 50 milligrams. Famotidine. Famotidine is also used to treat what? GERD. GERD. So we used to use Zantac and Etidine, but it's got a black box warning now for cancer. So it's talcum powder, so it's like everything. But famotidine, most nurses, you say, hey, get this ready, they're grabbing all that stuff. And vasopressors. So again, epi is typically what we're going to go for. Norepinephrine potentially back that. Glucagon if we're worried about beta blockers, and then any wheezing present, Strider, we can go ahead and give them some nebulizing treatment, rock to either albuterol. Maybe you want to give them a duoneb. Either way, definitely helps them out. If you're hearing wheezing, we hear something, we see something wrong with vitals, we need to be treating it. I went way over time, so we'll stop right here, sorry. We're only going to take 10 minutes, I know. We've got one more lecture to get through today, and I think what we'll try and do is we'll push through, we'll do a review, and then you guys can come in later tomorrow. Yeah? All right. We're talking about all these medications. So, only 1 in 4 are going to come in to be treated in the emergency department. So obviously if they're unstable, they are refractory to treatment, they should be admitted to an ICU where they can be monitored properly. So if they did get some IM epi, usually observed in the ED, they say approximately 12 hours, or sorry, 4 hours, approximately 4 hours. So want to maintain symptom-free up to 6 hours, discharge home. So less than 5 or 3% incidence.
So not likely.
Consider prolonged observation if they've had severe reaction or any of those people that are on an underlying beta blocker. So metoprolol probably being the most common. Longer observation for those folks that have social issues, meaning they live alone, they don't have good follow-up. So severe, make sure they leave with antihistamines, corticosteroids, and a prescription for epinephrine auto-injector. Most of the time when you order that box, it comes with 2. I tell the patient, keep one on your person and keep one close by, whether that's your car, a purse, whatever. So give them strong return restrictions and make sure that these people know exactly how to use that EpiPen. I usually tell them you're going to inject it into your thigh, you're going to feel the needle go in, and I usually have them count to 10 if they're administering the one themselves. Just to break down real quick, making sure that IM is going to be a different dose than if we were going to do it IV. That has become an issue, so that's why most emergency departments are actually carrying EpiPens, because they've messed up and trying to do crash cart epi. It's not the same thing. Not the same thing. Crash cart epi won't do the same thing as giving IM. All right, check on learning. Any questions on anaphylaxis? This is considered basically environmental emergency medicine for the most part. Very important that you know how to do this because you could deal with this any number of places. We need to do airway, okay? And I told you, if you get stung in the throat, you get concerned about that. But any type of food allergy, if it's in the throat, it's going to cause significant swelling there. And we need to manage the airway before we completely lose it. Plus, candidate for Crike is very difficult in a child under the age of 12, right? We don't even consider that. Thymus is too big, it's going to turn into a blade-less. Pretty simple. Epinephrine will reach first. It can be multiple doses. There is a YouTube channel where this guy lets all different types of things bite him, mostly insects. But all those clips are like 8 minutes long. That guy's crazy. So I could show you that, but I'm going to get into this type of thing. 37 slides. Bites things and other things. Reference material. Envenomations is really what we're gonna kind of roll this up to, the proper terminology, envenomations. So, first thing we're gonna talk about will be proper terminology, hymenoptera. Basically consists of bees and wasps. So, it's gonna contain histamine, which is gonna cause significant dilation of blood vessels. So, melatonin causes basophils and mast cells. That has a huge deal with our response here. So these are protein enzymes causing most systemic reactions, especially with that phospholipase and hydrolase. So most of these hymenoptera share the same type of components. So cross-sensitivity, meaning if you're allergic to honeybees, you're probably going to be allergic to wasp, and all the different flavors of wasp, yellow jackets, those types of things. So most common response, local reaction. So that's why I say almost everybody is allergic. So localized itching, some pain, some redness, and then swelling, that urticaria. So we do get concerned. If somebody gets stung around the mouth or throat, they're outside, drinking something, bee lands into it, and they swallow it. That's very concerning. We also talk about life, limb, eyesight. Talk about eyesight, stings around the eye can cause some pretty significant lid swelling. It can cause a cataract, atrophy of the lens, abscess. We do worry about globe perforation, and then glaucoma or refractive changes. So if you get somebody that's stung around the eye, it's very potential that you need to consult ophthalmology, not optometry, ophthalmology, an eye doctor. So usually within the first 15 minutes, up to 6 hours get these reactions. So we know that we're going towards anaphylaxis because we're having multi-system organ involvement, meaning nausea, vomiting, diarrhea, lightheadedness, syncopated, spasms, sometimes seizures, but rare, and then progressing to respiratory distress and cardiac arrest. So we don't have to have urticaria or bronchospasm. We don't have to have cutaneous or lung involvement to be considered that. So again, the quicker the onset of symptoms, the more severe it's going to be. So airway obstruction within the first hour, along with hypotension within 1 hour. Very important to get this stuff on board. So remove that stinger if it's present, and then washing that site with soap and water, making sure that we don't have a secondary infection that develops. Cold compresses can also be helpful for the patient, usually more in the kiddos. And then what else can we reach for? We can reach for NSAIDs or antihistamines to limit the discomfort, as well as the itching or pruritus. If that is in a limb and it's starting to swell and cause significant edema, we can elevate that limb. And then corticosteroids typically always used. But making sure we're maintaining those ABCs. There's your IM epinephrine dose. So 1/1,000. Anywhere from 0.3 to 0.5 mils in adults. And there's kiddo ones. So there are kiddo pediatric anaphylaxis epinephrine kits. So everybody know the adults are typically yellow, kiddos are green. Kiddos are green. So can you give a kid an adult one? Yes, you can. In a pinch, you need to. In a pinch, you need to. Aggressive fluid resuscitation, and then we talk about those medications. Same thing for anaphylaxis. So send those people home, please, with those three medications. That's all your hymenoptera. Make sure you know who these folks are that have this allergy. I'm a little more concerned if somebody doesn't know if they have an allergy. Maybe they've made it all the way to their mid-20s and they've never been stung by a bee. Those are the folks that I worry about. That's why I always carry extra EpiPens when I'm out in the field, because it may be the first time they've ever gotten stung, and that would really stink to find out that they have anaphylaxis from that point. I mean, talk to some of your classmates, they were treated it, probably given, had to give up to 5-6 EpiPens in one single person. All right, get into spiders. It's your number one spider. That is the brown recluse. So, in the indoors and outdoors, usually dark, dry areas, basements, closets, wood piles, type of thing. Violin pattern on the cephalothorax. Okay, that's going to be the thorax that's closer to the head. So these have multiple enzymes. So these cause necrosis. Necrosis, a little bit different from a black widow, a little bit different from black widow. So you will need to be able to differentiate. It's not super hard. The pants will ask this as well. So with these, painless, okay? Usually initially painless. That person's not going to complain of anything. I had a gentleman that got bit by a Brown Police and Ranger School, ended up having to go to the operating room because it was over a joint and it got all nasty and infected. He was good for the first 24 hours and then he came in severe pain. So painless bite is a mild erythematous lesion. So most of the time doesn't involve much at all. So that bite doesn't show up later, but then we get this hemorrhagic blister that can form. Specifically looking from day 3 to 4, red, white, and blue. That's erythema blanching ecchinosis. Very common pants question. You're going to say, how is that described, red, white, and blue? So usually didn't start pain right away, and then can become necrotic because of the specific types of enzymes. How do we treat this? Usually just supportive. We make sure there's no secondary infection. If an infection develops, we can put them on antibiotics. A lot of times, if they get necrotic, they're going to have to require some surgical excision, debridement. There is some credence for dapsone as being a medication that can help out if they are having significant effects. So, especially hemolysis and methemoglonia. So, dapsone can be used in that case in consultation with somebody. So, again, serial wound evaluation is key if it's necrotic or ulcerated. So, clear margins, usually 2 to 3 weeks. They delay that until 2 to 3 weeks after the bite, making sure there's no significant infection. And then if they are having symptoms, vitals are off, whether they're hypotense or they're hypertense, or they develop any sepsis secondary to infection, we can potentially bring them into the hospital. Now, here is the black widow. Again, that orange-red hourglass. The females are usually larger than the males, found in the same places that we find brown recluse, and these are considered aggressive. So, most active component is that A, letrotoxin. So, the problem with this is this affects on the calcium channels, and specifically the neurotransmitters, which causes neuromuscular manifestations. These people are going to have spasms. They're going to have abdominal cramping. So that has to do with this norepinephrine release, especially when it's affecting the cardiovascular system. It's going to see that significantly with different vitals. So typically hypertense and tachycardic. Painful bite right away, which is different from the brown recluse, which is going to be significantly delayed. This is right off the bat. And then that acetylcholine response causes significant abdominal wall cramping and pain. So have to look at these people, and maybe potentially treat that pain. So it's also going to help out that hypertension and tachycardia. Hypertension. Other symptoms they can have: headache, nausea, vomiting, diaphoresis, photophobia, shortness of breath. Very rare, but because it acts on those calcium channels, they can also have atrial fibrillation resulting in myocarditis. Weird thing, priapism. I think it's very interesting. So, what else do we see priapism in? What type of injuries? Spinal injuries. Okay, always an important thing to check. Not just rectal tone, but for that as well. So we see priapism, we're concerned about a complete disruption of the spinal cord, and then untreated typically only lasts for a day. But again, there's letrotoxin, again, calcium channel affected, that causes pretty significant neuro symptoms. Supportive measures. Sometimes if they are having some atrial fibrillation, some type of dysrhythmia, or concerned about that, we can give IV calcium. And if we're giving that peripherally, is that going to be gluconate or chloride? Calcium gluconate is given peripherally. Chloride is usually in the central line. C, central line gluconate. the opioid administration, low threshold to give that. Make sure you give it with an antiemetic. For our people that are narcotic naive, don't take a lot of those medications. They can become very sick. You want to be cleaning up vomit while you're taking care of their pain. And then benzos, also a possibility, whether that's lorazepam or diazepam. And there is an antivenom out there. Most places I've not seen this on their formulary. Probably somewhere where they say there are a lot of brown recluse mice. So maybe you need to admit that patient for severe envenomation. I figure they found like a nest up and it gets done by a bunch, usually for pain control. We don't send our patients home if they're having significant symptoms. We don't send our patients home if they have vitals that are off. That's the last thing the nurse is going to do is check vitals again and then discharge. I don't like sending somebody home with abnormal vitals. So if that person's tachycardic, maybe they need some fluids to bring that down. Maybe they're tachycardic because they're still in pain. So there's potential if you have the antivenin. I would just check with your MPF. So this is typically going to be military treatment facilities that are more in the south of the United States. That's where these exist, but they can show up anywhere because they can be riding in your moving van from site 1 to site 2. I see a lot of these in El Paso, southern United States, Texas. I've been stung by a bunch of these. Not horrible, but that's the bark scorpion. Bark scorpion. It does have enough venom to cause systemic toxicity, but I have never particularly seen that. Those things are usually just localized, but keep in mind this, unlike the black widow, this can act on sodium channels. On sodium channels causing prolonged and excessive depolarization. So what does that cause specifically? These people can have jerking in the extremities and seizure-like activity. So again, if it does affect the cardiovascular, the sodium channels within the pericardium, so that can cause tachycardia, hypertension, pulmonary edema, cardiogenic shock. These are severe cases where somebody's likely stung, stepped in a nest of scorpions. So they can have peripheral nervous system toxicity, manifest itself in ocular motor function, so pharyngeal muscle control, so specifically tracking cranial nerves, cranial nerves, and then some neuromuscular activity, tongue fasciculations. Another interesting thing, hypersalivation. Hypersalivation can occur. So looking specifically cranial nerve 5, 7, and 9. Here's your treatment. As you can see, most of this is supportive treatment. Most of this is just supportive treatment. Treatment of pain. I really just need you to be able to recognize a scorpion sting. For Bliss, it was fun for people to catch those and find the guy that was sleeping and throw it in his sleeping bag as not cool. So I can treat plenty of these. Usually just localized reaction, pain went away. Return precautions, make sure no secondary infection occurs, make sure there's no systemic symptoms. So get a good set of vitals, do a good neuro exam. If anything's abnormal, they can be brought into a hospital, evaluated further. And so I talked about snakes. This information is a little bit old. These are not very common. So 6,000 bites, about 1 in 3 of them is by a venomous snake. So that means a lot of snakes are biting. So usually in the winter months, because they have a tendency to hibernate and stay hidden in the winter months. So at one point it got up to 25%, but now we're down to less than 0.5%. That's because we have access to antivenom. So we're looking at only 5 deaths occur per year. Obviously it's going to be dependent upon where you are in the United States. So local tissue injury. So you have 3 different flavors here where it's going to be local, then it's going to cause systemic vascular damage, and then this whole idea where it causes hemolysis, fibrinolysis, and neuromuscular dysfunction. So it's going to be a combination of local and systemic effects, local and systemic. So you're going to see blood vessel permeability, which is going to cause significant hypovolema, as well as, you can see there, pretty significant echymosis. So, and it causes coagulopathy because that venom consumes fibrinogen and platelets. that's not good, consume fibrinogen and platelets. And then we can have neuromuscular transmission as well, causing things like ptosis, respiratory failure, and altered sensorium or altered mental status. About 1 in 4 is a dry bite. We assume that they are not dry bites as well. Other symptoms, complaining, GI symptoms, weakness, neurologic, so numbness, tingling, dizziness. So what do you see as far as vitals? These people are going to be tachypnic, tachycardic, hypotense, altered level of consciousness. Those are important to pay attention to those because these are going to be indicators for do I need to give antivenom, and I will give you specific things that we're going to look for. So usually within 15 to 30 minutes, we know that we probably don't have a dry bite. So they get bit specific place, we need to check for edema if they get bit anywhere near the neck, face, concern for airway, angioedema there, and then obviously significant progressive ecchymosis with these because of the leakage, because of coagulopathy that occurs. So presence of fang marks, we need to be looking for that, and then, hey, where are you walking? You're walking in a field, walking through brush. So we want to see evidence of local injury. We're going to look for hematologic abnormality, whether that's a thrombocytopenia, which is decreased platelets, a elevation in prothrombin time, or decrease in fibrinogen, and then looking for systemic effects as well. A lot of those are going to manifest through vitals. So 8 to 12 hours, we don't see any of those types of things. We can rest assured it's probably a dry bite, but we want to observe them for 8 to 12 hours. So antivenom is the mainstay. So how do they make that? Usually from horses, okay? These antibodies bind and neutralize to the venom molecules. So was that Profab used in the United States? Progressive signs. Here's your progressive signs. I would definitely know what is progressive signs here. So obviously worsening local abnormality. Now you need to think through your processes when we talk about laboratory effects. Worsening platelet counts. Platelets are going down. Coagulation time's going up because platelets are down. And decreased fibrinogen level because it is attacking the fibrinogen. And then you have unstable vital signs, altered mental status. Please be aware of those. You got to think through your processes that platelets are going down, but coag times are going up. And that negative feedback type of thing. So IV control, so making sure that we're affecting the local effects, the systemic effects, and hematologic abnormalities. That's what those are identified as. So we need to give that dosing right off the bat. If you look down at that chart, so right off the bat, 4 to 6 vials. Like having an idea how much a vial costs? Anywhere from 3 to 4 grand per vial. 3 grand, 3 to 4, based on where you are in the United States. So obviously Gainesville, Georgia, a lot of vials on hand because it's just a lot of snakes in the area. So 4 to 6 vials initially, and then could potentially go to more. So you're looking at 4 to 6 vials. I mean, you're talking about closer to 20 grand for your first dose of that. So what I'm saying is that you really need to be sure that you're going to pull a trigger on this. You really need to be sure that you're going to pull a trigger on this. Okay, if you can't get IV access, we go right to IO. Everything that you can put in an IV, you can give in an IO. So we don't do this rabies thing. It's not rabies. We don't inject the antivenom right into the wound. Okay, it has to go into the entire body. So, the entire body. So, make sure that we check, make sure the progression of edema. A lot of times it's good to measure these extremities so you have an idea, is that edema progressing? It's easy when we're dealing with cellulitis so we can mark the edges of that, right, with a marker. But with this, it's good to have some type of measuring device so you can measure the circumference of a calf, circumference of a forearm, a bicep, whatever, and then continue to monitor those to make sure that it's getting better. So we measured that. And they're saying every 30 minutes. So advancing border of edema potentially, but and then laboratory determinations every 4 hours. Every 4 hours. Again, like It's a big deal if you have somebody come in with a snake bite, because we don't see these a lot. We do not see these a lot, but you need to know how to treat that. So, patient worsens or fails to improve, additional doses of antivenom, So, and then make sure giving fluids. If they're still hypotense, we can get vasopressor on board. So vasopressor on board. And then there always potential to transfuse our patients. So why? Is this affecting actual like red blood cells, white blood cells? No, it's affecting platelets. It's affecting fibrinogen. What do we have to reach for as far as our coag factors? That is going to be fresh frozen plasma. It's going to replace the fibrinogen, the factor 5, the factor 8, and the factor 10 fibrinogen. So 6 to 8 hours, making sure it's not a dry bite. If it gets better, we potentially discharge them. Most of these patients, so if they get antivenom, period, they're not going home. Antivenom has to continue to be monitored. It goes to an ICU. So if a patient is getting antivenom, they're not going home. They're not going home. They have to come into the hospital. So outpatient, making sure if they do, when they do go home, need to be monitored for infection and serum sickness because of the antivenom. Are you familiar with this guy? Lapid, something that you will see in San Antonio. I've seen several of them, known as the coral snake. You got the old adage right there, red on yellow, kill a fellow, red on black, venom black. That's because it's confused with what type of snake? The king snake. Okay, coral snake, neurotoxic components, no local injury. So they essentially chew on you. There's an antivenom out there, so we should have that here in San Antonio. I'm not sure how much this would cost, but 3 to 5 vials, I imagine it's going to be at least that of the rattlesnake. So, and then again, if the symptoms do not improve, there's potential for additional vials. So, want to make sure only in cases where it's clear clinical identification of the snake, and then we need to have laboratory evidence. So, a lot of these people will tell you, yeah, I'm pretty sure this is really got bit by. A lot of neurotoxic effects with these, more neurotoxic effects. So, ptosis, cranial nerves, muscle weakness, and then what's concerning about that is diaphragmatic involvement. These people might have difficulty breathing. And then all these other issues that are similar to that. So we're saying at least 12 hours in the emergency department for observation. And if we can't get IV access because maybe they're hypotense, we go IO. No IM administration of either of these antivenoms, not even in a pinch. All right. Check on learning, and then I'm going to pull up the test. And again, you pay attention to your check on learnings. It should be good. Everybody did okay on the test today?
Yes.
Questions on bites, stings? So we talked about that red, white, blue, right? All right, yep. So it's brown recluse. You need to know what those progressive symptoms are. And I said, so it would be the opposite of thrombocytosis, right? Thrombopenia. It would be decrease in fibrinogen. Prolonged coagulation times, and then we talked about other things, so hypotension and altered mental status. So altered mental, abnormal mental status, right? Let's see. So pay attention to all those check on learnings. That was your first review. I'm just going to go through some things that I think that maybe I don't necessarily address. Exactly. If I repeated something, I repeated it for a reason. Get that one. Definitely, you should take a deep dive in cerebellar infarctions. How do we treat sepsis? How do we treat seizures, especially with alcohol use? When I tell you you're gonna calculate 3 separate GCSs. That's how much I want you to know that. So if you want to miss out on 6 points, don't study that. Not that hard. Very important though, GCS. Feel good. And a lot of these are. Pay attention to those. Check on learnings. Why do you get a CT and not a seizure? Why do we get an EKG and BK? I would read up on dissections. Definitely read up on management of strokes, ischemic strokes. Read up on giant cell arteritis. Idiopathic intracranial hypertension. You guys are going to be told. We definitely know the difference between brown recluse and black widows. And I got several snake bite questions. Check on learnings. And you're gonna hook that up for tomorrow?
Yep.
I gave you back 2 hours of your lives.
Thank you.
Sorry for earlier once or twice and whatever. I didn't go too fast today.
Perfect.
Some people, somebody's like, too slow, too fast. They cancel each other out. I will be teaching you block 3, major Sandoval view 2 and 4, and I don't know who's going to teach you ultrasound, but we shall see. Any other questions, concerns? I'll hang around here for a few minutes. Okay, just make sure you really look through that so you understand. I mean, there's permissive hypertension, and then there's not. And those are people that lower their blood pressure. If they can't get it down, then you can't give them thrombolytics. But if we get them down, they are candidates, provided they're in the proper window.
Thank you, sir.
Too much time back. Too much time. Definitely.
That's going on.